All right, well, welcome. Today is what we call our State of the State. So we just want to tell you a little bit where we are at the UAB Lifespan Comprehensive Sickle Cell Center. I'm Julie Cantor, and I'm co-director along with Dr. Jeff Liebensberger. And so you get to hear from both of us. You don't have to hear my voice all morning, which is great. And I'm excited to have everybody here and welcome you. So this is just an overview of our comprehensive sickle cell center here at UAB. You can see on the left is our adult program, and on the right is our pediatric program with multiple joint initiatives, as well as our Love Investment program in the middle that I'm going to go into some detail on, and our community engagement and outreach program as well. We'll review some of the goals of our center. We'll talk about the adult program and the clinical and research initiatives that we have, the pediatric sickle cell program, and the clinical and research initiatives, the joint initiatives, and our Ted and Joyce Love investment. So starting with our adult program, we really use a multidisciplinary approach in our approach to sickle cell disease care. And I think that's at the foundation of what we do in the UAB adult program. Working with the understanding that as the sickle cell disease specialist, we're just part of a very important team. And without one cog in the wheel, our wheel doesn't turn very well. So importantly, we have our nurses, our mental health care providers, our community-based organizations, our care coordination, our embedded primary care physician, our novel therapies, our social work, and our transition program, all of which make up what we're trying to do, which is help those individuals living with sickle cell and their care family, whether that's their children or their parents or their friends that make up their support teams. And our goals are to really serve as a hub for any adult living with sickle cell disease in Alabama. I know most people are aware that I feel it's most important that every individual living with sickle cell disease have access to a sickle cell disease specialist, and that at least on an annual basis, everyone needs to be seen at least once a year. Our goal is to ensure that everyone gets the offers to all of the sickle cell disease modifying therapies, and specifically that people understand why they're being offered these therapies. That chronic red cell transfusion and apheresis therapy are readily available, that we have an iron chelation program, and that we are working hard to improve that. Comprehensive pain management that includes both chronic pain management as well as outpatient IV treatment in our day hospital, and then Suboxone for opiate-induced hyperalgesia. We want to ensure that individuals have access to mental health care and primary care, stem cell transplant, gene therapy, and autologous transplant. We, of course, pay a lot of attention to our transition program to ensure that our young children and teenagers make it across to UAB without difficulties and ensure access to novel therapeutics. Our multidisciplinary program has grown significantly since I've been here at UAB. We see over 800 individuals per year living with sickle cell disease, and the referrals keep coming. So it is really impressive to see just how many individuals live in this state with sickle cell disease and how many need care. We've had actually 200 new referrals in the last 18 months. We have clinic 5 days a week. We have 3 MD days of clinic, soon to be 5, as Dr. El Nassah joins us. We're counting down the days, some of us the hours. And our APP clinic every day, as well as infusion and therapeutic and transfusion access. We even can do transfusions on weekends now. We have our dedicated outpatient team that is specific to those with sickle cell disease, as well as our social work team, our clinical staff, our pharmacists, and we see at least 120 visits in our clinic weekly. We've also developed multiple partnerships at UAB that have really improved care. Probably the one I'm most proud of is our partnership with the emergency department, where we have a significant improvement in communication and that we are working hard to make sure individuals get their individualized care plans. We also have an inpatient partnership I'll tell you a little bit more about with our hospitalist service that's also really been effective in improving individuals getting their care plans when they're in the hospital. We've done over 15 transplants now with our stem cell transplant program. We work closely with our apheresis and blood bank partnerships, with radiology, and multiple other subspecialty partnerships. Our transition clinic started in 2019. And obviously, we have amazing expertise at Children's, and so we want to make sure that individuals don't lose time or space or therapy between children's and adult care. So we go over to Children's, myself and Terica, our transition coordinator, in order to see patients monthly and have them get to meet us and realize maybe we're not as scary as we seem, and they get to ask questions and get additional information. We're also trying to ensure that they're enrolled in the Granddad registry before they come over to the adult side, as that will actually really help make sure we have all of the information about them. We're using Got Transition metrics, and we're trying to enhance practice harmonization between pediatric and adult care, so it's not such a surprise when they come over to the adult side. And then we're going to increase that to 2 transition clinics a month when Dr. Saad joins us. UAB has really seen a large number of individuals with sickle cell disease, and you're going to hear a little bit more of our all-state database, but that's allowed us to identify that 2,263 unique individuals with sickle cell disease have come into UAB since 2008, and that we have about 845 adults in our current sickle cell disease database at UAB. So how does that translate to care in our emergency department? Well, when I came into the program early in 2019, we were seeing an average of about 60 to 70 visits in the emergency department per month from individuals with sickle cell disease. And one of our goals is to move more of the care from the emergency department to the outpatient care, where we know that they can have better individualized care and, of course, less risk for things happening that we don't want to happen. And so we've slowly improved upon that, which you can see here. So specifically in 2017, there were over 1,400 visits, averaging about 70 a month. As we started our program and gained traction, we decreased that by about 60%. Now, this was during COVID, so we know there was a decrease overall in the emergency department during that time. But we've continued to see a sustained decrease in which we've seen between 380 and 526 visits in the ER per year, averages around 40 per month, and that's a decrease of about 40% from the past. That was leading up until 2024. Now, when we look closely at unique visits, we're still seeing a downward trend, despite the fact that we've significantly increased the number of individuals that we take care of. So I'm planning to go back to plot this per number of individuals that we take care of, but we've substantially decreased that emergency department burden, which also means that when individuals present to the emergency department, our ER is very quick to know that they need to be there. What about our inpatient care? So when I joined UAB, I did warn everybody that we would be increasing the size of our program and not decreasing it, and that might increase our numbers in the hospital and not decrease those. That actually has not come to fruition, as we've seen a slow but steady decrease in our inpatient admissions per month, both at UAB and UAB Highlands. And when we look specifically at those individuals we take care of, so the previous slide was all individuals with sickle cell disease. When we look specifically at our individual cohort that we take care of, you can see that we've decreased by about 100 visits to the hospital over time. So we hope to continue doing this, as we feel like the more that people are not in the hospital must mean they're doing better. We also have an inpatient e-consult program. Dr. Gunchale helped me start this. I say she started it. She says I started it. We haven't decided, but it was definitely a joint effort in which when individuals are admitted to the hospital, we get an automatic notification within the EMR system. And with that, we can put in a note that really just details their individualized care plan. What do they need in terms of pain management? What type of transfusion therapy should they have? Making sure that they're not getting excess IV fluids, recognizing when they're developing other complications such as acute chest or splenic sequestration. We try to follow them daily electronically when they're in the hospital. So as one individual, we can't see everyone, and eventually we do hope to have an APP service in the hospital. But right now, this is a good translation of how we can make sure people are getting their individualized care plans. And then we make sure they're followed up within 7 days. And when we look at the effect of this program, the first thing we noticed was a significant decrease in readmission rates. Again, this is looking in the blue at readmission rates within 15 days, and the orange is readmission rates within 30 days. And you can see a significant decrease since we started these e-consultations. Consistent with that, we see an improvement in follow-up. So blue again in 7 days, now orange in 14 days. And our goal is to have everyone followed up within 7 days to the inpatient side, to the outpatient side if they've been in the hospital. And you can again see a significant increase where only about 20 to 40 individuals were following up previously within 7 days of hospitalization. And now our follow-up is significantly greater. Now, importantly, we need to look at these numbers per admission, so we'll be working on those data points. So when I first came, I set out some quality improvement goals. One is consistent with sort of the national goals of making sure that when someone presents for a pain crisis, they're getting pain medicine within 60 minutes of presentation. And while we have not moved this needle as much as we would like in the emergency department, just because they are so busy, we have moved the needle substantially for people coming into the day hospital, and we're actually at 100%. So everyone who walks into the day hospital or the infusion therapy unit, as we call it here at UAB, does get their target medication within 60 minutes, and most within 30. We've also increased our opioid use monitoring, routine drug screening, and PDMP assessments to make sure that we are using opioids safely, and that's at 98%. Our hydroxyurea use, specifically targeting people with sickle cell anemia who are not on transfusion, is at 85%. And our stroke prevention therapy, which in the adults is offering chronic red cell transfusion to anybody with a history of stroke. We offer it 100% of the time. We get acceptance from those individuals about 75% of the time. So with these improvements, we wanted to set some new goals for quality improvement moving forward. One of the biggest is improved retinal screening. So we really want to make sure that everybody over 10 years of age has a retinal screen every year with an ophthalmologist. And this is proven quite challenging for a number of reasons, not limited to the fact that in Alabama, Medicaid only allows for one screening assessment every 3 years. However, it does allow for you to code sickle cell anemia as your reason for visit as opposed to screening, and it will be covered. So now that we've identified this, we're hoping that will help us get more people into care. It also is difficult because our main partners in this, our Callahan Foundation here, has a different EMR system that we can't see, and they can't see our EMR system. So it's hard to always get the data to know for sure that someone has made it to those visits. We also want to ensure that every individual on the adult side, also the pediatric side, has a primary care provider and is seeing that primary care provider as well. And so we want to increase the number that we can identify, have a primary care visit, and are getting all of their necessary screening testing. And then we want to ensure access to psychology and mental health care. And we're going to make sure we talk a little bit more about that when we introduce our LOVE program initiatives. We're also quite committed to research in sickle cell disease and have a truly amazing research time. Yes, I do have all your pictures. If you don't like them, send me a new one. But I can't thank our research team enough for everything that you do and for all of the important trials that you help us move forward. We also have amazing research faculty and postdoctorates. We have Dr. Patel, Dr. Morais, we have, Dr. Torres, we have Dr. Galadanchi, Dr. DuPont, and Dr. Mohammed. And so each of these individuals, I'm going to tell you about their research individualized in just a moment. We still have multiple federal funding initiatives that are ongoing, and I'm going to tell you a little bit more about these as well. My favorite, of course, is our recipe project, where our goal is to reduce that number of unaffiliated patients. As I mentioned, one of my primary goals, not just here in Alabama, but across the United States, is to ensure that everyone living with sickle cell disease has access to a sickle cell disease specialist. In this day and age, we have over 120 recognized sickle cell centers. There is no reason we cannot work with our payers and with our state partners to make sure that everyone is getting to care. So as part of that, we needed to figure out what those barriers were and where we found people who were unaffiliated. And so this is a large funded effort from the NIH to link and identify unaffiliated patients to care. So we're using sickle cell disease surveillance, community-based and hospital-based pathways to identify these individuals. We're linking them to care with a linkage coordinator. This is an implementation adapted from those individuals treating HIV to engage those unaffiliated patients, make them feel more comfortable in approaching the healthcare system who might have abandoned them or worse, stigmatized against them, and discussing the benefits of engaging care with a sickle cell specialist. And then understanding the factors and the implementation support that we need to enhance and maintain these practices and sustaining them and scaling them out. We also have our HRSA effort, as many of you are familiar with, the education and mentoring to bring access to care for sickle cell disease, our EMBRACE project. This is a collaboration across the Southeast where we provide funding to state providers in every state of our region to ensure that we can continue to enhance practice harmonization and also bring people into care. And of course, ECHO is a big foundation within this, in which we have bi-weekly ECHO tele-mentoring sessions, and we include those in our residency programs as well. We have ECHO sessions for our community oncologists, primary care providers, And most importantly, we're part of the support program, which is an APP training program that was sponsored by HRSA and has been undertaken by the National Alliance to continue to support our APPs in becoming sickle cell specialists. We have multiple NIH-funded studies for which we're a site and not the primary lead. And that includes our sickle cell disease care study, which looks at the use of apheresis to improve cardiovascular, pulmonary, and red cell problems associated with sickle cell disease. We're looking at mechanisms of venous thrombosis and renal dysfunction in sickle cell trait, led by Dr. Nigel Key. And I'm going to leave the screen and SMILE study for Dr. Liebensberger to tell you more about. We also have multiple foundation and industry-sponsored studies. We'd be here till tomorrow to go through all of them, but these are the ones that I wanted to just highlight. Our trials of etavopivat, which is a PKR activator to improve the health of red cells, our Affimmune trial, and some new studies of Novartis and Bristol Myers Squibb, both of which have what are called WIZ degraders. These are novel therapeutics that will enhance and implement the development of fetal hemoglobin in a way that's not involving epigenetic changes and in a way that is not dangerous to the bone marrow and not a chemotherapeutic agent. So we're hoping this is an alternative for people who have been reluctant to hydroxyurea or an additive to hydroxyurea to further increase their fetal hemoglobin. We're also starting on a trial with Sanofi, looking at this word that I have trouble saying, rilzabrutinib, which has actually been looked at already in ITP and is a really interesting immune modulator that may also decrease some of the problems we see in sickle cell disease. We, of course, have our genetic therapy studies, our Bluebird gene addition studies, which are HGB 206, 210, and the long-term follow-up study. Specifically, these are our gene addition studies. And then we have our Beacon study sponsored by Beam. That's a phase 1 to 2 trial with a base pair editing mechanism. So different mechanism of action to increase fetal hemoglobin. And then TREAT is not actually a genetic therapy study, but it apparently is listed here. So our foundation-sponsored studies, we also are working with the National Alliance on AUNT, which is a sickle cell trait study that is yielding some interesting results. The goal of AUNT is to see if we can identify if there are specific individuals who could be at risk for actually having complications of sickle cell disease, especially when stressed with hypoxia. Here's TREAT where it's supposed to be. It's our Dr. McGann leads this, and it's a idea that we can identify and personalize hydroxyurea dosing for adults. We also have AHA funded program through Dr. Galandanci, which is looking at cardiac screening implementation. And we have funding through the ASH Sickle Cell Disease Clinical Trials Network to improve clinical trial enrollment and the use of a National Community Advisory Board. We have Grandad, which is our Global Research Network for Data and Discovery. This is one of our other most important initiatives where we're really trying to enhance enrollment because we can use this not only to ensure that patients are getting the care that they need, but to track that care and compare to national standards for quality improvement. It's also so that we can help identify and personalize care in the long term for individuals living with sickle cell disease. And as I mentioned, some of our investigator-initiated projects, Dr. Patel is exploring the cultural values and palliative care preferences of adults living with sickle cell disease, really to define palliative care for adults with sickle cell disease-related serious complications. What do individuals want as they approach end-of-life complications, or even before they get to that point where they have more complications than we currently have treatments for? And how can we enhance their preference in what we're doing to make their care better? Our work by Dr. Mohammed and Dr. Galandanci on troponin is a potential biomarker in sickle cell disease. We've just applied for additional funding, as we've identified many individuals have what's called a troponin leak when they come in for a crisis, despite not having cardiac symptomatology consistent with a normal heart attack. And so we're trying to understand if we can use this as a predictive biomarker, either for heart failure or in the setting of an acute crisis. We're also working with Dr. Mohammed and Galandanci on our Uber Health program. As many know, we use Uber Health a lot in our program. And we know that transportation barriers are a major challenge for people with sickle cell disease, as well as other chronic conditions. And so we haven't highlighted this in a way that we think is important. So we're really trying to highlight the use of Uber Health and trying to demonstrate how effective it's been in decreasing no-show rates and improving adherence to care, and also looking at how we're using this in the acute care setting. And then we've been working closely on the use of Suboxone in chronic pain and sickle cell disease, also for opiate-induced hyperalgesia. We did a real-world implementation of the David Carroll protocol. We did this with Dr. Torres and Galandanchi, and what we're hoping now is to get additional funding, and we're currently applying for a PCORI grant. And Dr. DuPont, even though she's leaving us not too long, we've been very excited to have her here working on VESGen. This is a novel method for mapping and quantifying ocular blood vessels. If Tamara New is here, we're sending Dr. DuPont to Tampa, so we hope that you'll welcome her with open arms. But we're also hoping to continue some of this work as we've really been able to identify some exciting outcomes, and she'll be presenting those in a couple more weeks. And it's really been an interesting study to understand how this works and how we might be able to use the eye as a prediction into complications in sickle cell disease. Then we have our sickle cell disease surveillance program, one of my favorite parts of what we're doing, looking at how sickle cell disease affects the population. In the Alabama Lifespan Sickle Cell Tracking Access Towards Equality or All-State program. And this has helped us identify far more individuals than we realized had sickle cell disease in the state of Alabama. This is the CDC-funded project as part of the SCDC. And importantly, we couldn't really understand just how many affected individuals there are without this program. It is now in 16 states, and it's something we're fighting to keep funding for. We have multiple ways that we capture and link data. We get databases from the sickle cell disease centers across the state. We then link that with newborn screening data, Medicaid data, hospital discharge data, as well as vital records data. And from there, we can import, and Amy Miles is magical in how she can link and deduplicate these individuals to identify the number of affected people. While doing this, we have levels of confirmatory diagnosis. So you might be amazed at the number of people who get a sickle cell disease diagnosis code within their chart when they don't have sickle cell disease. When we went through the UAB system specifically, only 10% of the people who had a code for sickle cell disease actually have sickle cell disease, which is pretty appalling. That means we're pretty bad at coding. However, we have identified some ways of narrowing that down, either by CLIA certified lab results. So if you have an electrophoresis, or if you have an HPLC, or if you have a clinical diagnosis, or if we understand that you have it in what we call an administrative definition, which is 3 or more codes on separate healthcare encounters over a 5-year period. We've enhanced that definition a little bit more here at Allstate. We've added a level 0. Those are people who don't have sickle cell disease. We have an electrophoresis that confirms it. We have a level 3 that means that we don't think these people have sickle cell disease. We don't have an electrophoresis to prove that they don't, but we're pretty sure that they don't. Or level 9 is those people with sickle cell trait. And using that, these are the number of people we think do have sickle cell disease in Alabama. These are our level 1 and level 2 confirmations. And what the stars indicate is the areas in which those individuals live. So we know the majority, or not majority, but a large number live in the Birmingham area and utilize UAB. We also know the number of individuals use Baptist in Montgomery and USA and Mobile Infirmary in Mobile. So we know those are 3 of our greatest areas where we need to improve care for sickle cell disease and ensure that each of those locations has an affiliate clinic that specializes in sickle cell. You can also see quite a number of individuals on our Medicaid platform. This is important as we consider current legislation. And with that, I'm going to turn it over to Dr. Liebensberger to talk about pediatrics.
All right, great job, and very impressive adult program. So just going through the landscape of pediatric patients in Alabama. So we have 1421 sickle cell patients that have been identified from Allstate, and you can see the location. There's 3 centers of care. So UAB provides one, the Johnson Haynes Jr. MD Comprehensive Sickle Cell at South is the second one, and then the St. Jude Huntsville affiliate. And as for those of you who know, we have both programs at Children's of Alabama, but we also go to Montgomery, Opelika, which is right near Auburn University, and Tuscaloosa to do outreach clinics. So we drive on Fridays to one of those locations. So quickly give you an overview of what we'll be talking about on the clinical side, and what we decide to focus is on sort of our metrics of success. And again, trying to put out data that sometimes is underwhelming to make sure that we achieve our metrics for next year. So one big issue we have is we transition to Epic. You guys are transitioning to Epic, right?
27.
In 2027. And so, again, a key to a large program is having a good database to make sure we know who our patients are, what they've had, their screening, everything done. But we have this issue in that all scripts, we had 931 patients, 0 to 19 years of age. Right now in Epic, we have 878 patients. And you can see, particularly in these younger age groups where we definitely have more patients, we're just, missing, who they are right now. And some of that's because we have to do some hand um, entry in Epic. And so if a provider forgets to go into the database portion, click that they have sickle cell, it's not being captured on the database as opposed to an automatic poll, which would obviously, or an automated poll, which would be a lot nicer. So here's our satellite clinic programs. So again, in blue are the programs that we're not affiliated with. So Madison is where the Huntsville St. Jude affiliate is. In Mobile is where the USA program is. So these are where we drive to. And the nice thing is we think that improves access to care. I know when they started this, so Dr. Howard and Dr. Hilliard, when they started this, really felt like access to care was a big issue. And so when they went out to these communities, they really improved the number of patients who were being seen. We've done a few studies on the differences between off-site or satellite clinics and the Birmingham affiliate, and we've shown in both cases very similar results. So no statistical difference between whether or not a patient, when they come to Birmingham, the benefit is we get our labs, we get hemoglobin Fs, we get all this, right away. We can make hydroxyurea dose adjustments. For our satellite clinics, it's really hard because on the way home, the lab in Montgomery, for example, will call us and say, hey, there's a hemoglobin of 6.2, but this is on a patient who was seen at 8, went to the lab, but they don't report the labs till later in the day. And then at 4 p.m. when they have faxed over the stuff, then we have to look through and see, okay, who do we miss, especially those with severe anemias. But regardless, then on Monday, we go through systematically assessing whether or not we increase or decrease dose of hydroxyurea. So there is that concern, are we appropriately dosing hydroxyurea when we do it via telehealth after the visit rather than in person? And then the second article, we looked at, those patients with and without MRIs, the amount who have been accepted on or accepting of hydroxyurea, and again, showing no statistical difference. So what we're working on right now is being seen by a sickle cell provider. So we do really well with our infants, right? Because a child's born with sickle cell, the parents come, they get a lot of education, which we track. But then after age 2, the education program that we have to educate the families stops. So that's why we figured we'd look at 2 and up to see how well we're doing. And again, we see these disparities that are statistically different between those who have sickle cell anemia and those who have non-sickle cell genotype. So usually S beta plus and SC. And so here what it just shows is within the last year, we're still not doing the best job. We'd like to capture 100% of our patients. But again, about 80% of patients with sickle cell anemia and 60% with the non-sickle cell anemias. So now that we've identified them, the goal would then be to identify them and then get them in. And so Dr. Chance, one of our fellows, is going to be trying to identify what were the barriers to continued participation in our sickle cell program. So the next thing is to improve the percentage of patients on a sickle cell modifying therapy. So again, a big difference between pediatrics and adults is not only the time of living with sickle cell, but also the decision making of the family versus the patient. And so not only do we have to get the patient to take it, but a lot of times we're convincing a parent to take it. And a big barrier that we have, especially with those who start late, is what used to be a mindset that we had that's changed in the last 10 to 20 years of, well, let me see if my child has any problems, and then we'll accept a sickle cell modifying therapy, as opposed to starting it early. So among all sickle cell patients, only 35% have been prescribed or receiving a sickle cell modifying therapy within the last 12 months. Um, of these, we have another 49 patients who have been prescribed hydroxyurea. So we've marked it in our database that they're on hydroxyurea. But when we look at pharmacy fills, they have no hydroxyurea filled in the last year. Now, those again who we definitely want to be having prescribed hydroxyurea is those who have SSS beta 0 thal, so are severe genotypes. Of those, about 64%, as you can see there, are receiving it. Again, we still have those who we have as prescribed but not filling it. So overall, 53% really receiving it. So one thing that we've tried to change is, and this comes from the Cincinnati model, we think we do a really good job with penicillin. So penicillin, for those who don't know in the adult world, started after the newborn screen is positive and continues to 5 years of age unless they've had 2 events. But anyways, what we believe is most of our patients are accepting of penicillin at birth. Well, why then at 9 months of age, when we offer hydroxyurea, do they say, no, we're going to wait to see if there's any problems? So I think we're doing a better job of using the Cincinnati model, which simply says, hey, when your first visit, we're starting penicillin now, and at 9 months, we're going to start hydroxyurea, and you just tell them, based on what we believe is the ethical of it's the right thing to do with patients with sickle cell anemia. And we have done a better job of getting patients accepting of hydroxyurea. We still struggle with those who have not been on hydroxyurea for 10 years, and now we continue to try to talk to them about it, but they're like, I don't feel like I need it. So again, working hard to get those babies started on it. Another issue we have, so if you were to look at the St. Jude data where their mean fetal hemoglobin is 20%, so again, fetal hemoglobin is one marker of hydroxyurea adherence. Um, you know, ours are around overall 12%. So again, no statistical difference whether they live in Birmingham or the satellite clinics. But again, we're doing, we could improve on our hemoglobin Fs. And what you can see here when you look at the overall standard deviation of 7, so what that really tells you is we have some of our patients who take hydroxyurea and they do it well and they are above 20%. And then on the other half are prescribed hydroxyurea and their fetal hemoglobins are 4 to 5%, suggesting they're not taking it. So while the overall mean is 12%, it's really split between those who are taking and those who are not. So it's to us, it's not as much about dose titration. It's about adherence to therapy. So again, another thing that we're working on in terms of improving outcomes. In terms of stroke screen, so percentage of patients with annual stroke screen. So again, something that Janine worked really hard on to make sure we have everybody. So 83% TCDs done on SSS beta 0, and we've only identified 40 patients who have not had one. In terms of those performed last year, about 80%. And that those numbers are a little bit off because if you have a condition or abnormal, then you do them again. And the other issue is in terms of these numbers, where it's 80%, some patients we, put in that they need a TCD, they don't show. So we schedule them a month later for TCD, they don't show. So that's why that number is actually a little bit inflated because it doesn't include no-shows. And then Hope and Cope program. So again, we really struggle with mental health. I think obviously everybody does. Our problem is our cancer patients also suffer from mental health, as do our bone marrow transplant patients. And we have one psychologist right now who's overseeing all of these patients. So again, you can imagine it's just really difficult to get access to mental health care at our center. And then again, this is data from Julie and Hannah. The importance of getting it here, or at least in a telemedicine through here, because we have a ton of counties who don't have access to a mental health counselor, to a licensed psychologist. So those are some of the clinical issues that we're trying to address this upcoming year. In terms of the Lifespan Sickle Cell Research Program, italicized those who are more on the adult side. But again, we have a large breadth of sickle cell researchers here. In terms of our renal program, so real quickly about our R01, what we learned is we need a new GFR equation, and we've talked about this data before, but this is coming near to the end, and we're going to start working on developing a sickle cell specific eGFR equation. Unfortunately, it's our first meeting with or without. I don't look at the participant list, whether Gosha is still on the calls. Um, but again, we have this basic translational science renal program, and our goal is to translate some of our basic science work here, showing that endothelin 1 is a contributor, and if you block endothelin 1, you can improve sickle cell kidney disease, and we're working on trying to get that into a clinical trial. And then I just have to get off the mat with my new non-discussed R01 to resubmit. But what we show here is that we have this issue with albuminuria too, and so we have some aims trying to look at that. What's really exciting for those of us in the sickle cell world in terms of kidney is our clinical work shows that APOL1, so this is APOL1 right here, this is a mutation that is nice in that it stops you from having sleeping sickness if you live in Africa. The problem is it does so by boring holes in this parasite. It also bores holes in the kidney. So if you have that, you are also, whether you have HIV, whether you have sickle cell, whether you have a lot of diseases, are going to be more likely to get kidney disease. So we have a sickle cell mouse model. They've developed an APOL1 model, and Gosha and the Pollocks have worked really hard. And so we now have our APOL1 sickle cell mouse model that's now maturing. So they took these two backbones, put them together. And so what's nice is we can then start looking at the natural history of APOL1 in the sickle cell mouse model, and then do some clinical trials first in the murine model. In terms of psychosocial and renal, so this is Dr. Brodnack. She is now in Louisiana, but she had an ASH award to look at social determinants of health. It was a fun project in that what we showed on the clinical side is that those who lived in deprived neighborhoods have about a 90% higher odds of developing persistent albuminuria. So something about being from a deprived neighborhood contributes, or at least is associated with persistent albuminuria. She tried, her main focus was on food deprivation. And so she tried to deprive mice of normal feeding by letting them eat during the daytime, but not at nighttime. So to try to mimic food insecurity. Turns out their weights were the same. So I think, unlike humans, they just like, all right, there's no food when I'm supposed to eat, but there's food at night. So maybe they psychologically didn't have the impact of worrying about food insecurity. Amar's here. So Amar's done some fantastic work in terms of the role of heme and free heme on acute chest syndrome. And so, I'll give it a quick blurb or just what we have up here.
All right. So we published this paper a few years ago, and it was selected as one of the top 10 papers by NIH for that year. Based on this study, we showed that hemopexin is very helpful in acute chest syndrome in mouse model. And since then, we've been working on developing a recombinant hemopexin that can be produced in commercial amounts at cost-effective way. And we are at the final stages of this. So we are testing the pharmacokinetics and dynamics on mice right now. We'll treat mice with the recombinant hemopexin that we have. It's plant-based product. So hopefully that would be tested to treat the different end organ complications of sickle cell disease in the coming couple of years. And we are submitting grant in June about this recombinant hemopexin. Other work that we've been working in the lab, we developed acute chest syndrome model in mice. We developed also pulmonary hypertension model in sickle cell disease mice, because those are the two main complications that I'm interested in. We're working on the clinical side also on determining the effect of sleep disordered breathing, especially nocturnal hypoxemia on sickle cell complications. We published few papers over the last few years, and we have 2 in press right now about the significance of sleep apnea and nocturnal hypoxemia in increasing the complication of sickle cell disease. On the clinical side, we have the acute chest syndrome clinical pathway that have been going very well. However, with the EPIC introduction, we have some glitch, but now we're back to full force. So we started this protocol to start acute chest syndrome management earlier in the ED and then in the floor, and we showed that this decreased the length of stay in the hospital, ICU admissions, and mortality of the last few years. We have also the pulmonary clinic that I staff twice a month to see only sickle cell disease patients who have severe asthma, sleep disordered breathing, hypoxemia, and pulmonary hypertension. We have been collaborating with Dr. Elonze to study the pulmonary hypertension in sickle cell disease, both on the pediatric and the adult side. And I've been working with Dr. Galandeshi and with Dr. Daiki on collecting growth data of young children with sickle cell disease to see if nutritional status during the first few years of life will have an effect on the later complications, especially related to the lungs. I'm also offering some educational kind of activities about sickle cell disease complications, pulmonary complications of sickle cell disease to our fellows once a year. I have a state of art and one journal club per year, just to educate our pulmonologists and cardiologists about the cardiopulmonary complications of sickle cell disease. So this is kind of my role in the program.
All right. Thank you. So this is Dr. Purnell. So she, we'll talk about two of her projects. So this was her KL2 award, looking at adverse childhood experiences being associated with increased prevalence of asthma and pain and acute chest syndrome. So again, similar to work that Dr. Pollaks have done in the lab, which is this neat model of if you take a mouse away from the mom for just an hour a day for the first week of life, they develop long-term issues like hypertension and this cardiorenal phenotype. So what she looked at is both pain on the y-axis here and acute chest syndrome events on the y-axis here. And then she plots on the x-axis the adverse childhood event scores. So those who have more adverse childhood experiences. In both of these, you can see that those who experience increased adverse childhood experiences have more sickle cell complications. And again, she presented several years ago, but it always sticks with me when she says in her qualitative interviews, somebody says when they hear gunshots in their neighborhood, that's what triggers their pain crisis. So again, making sure we think about, the whole patient and especially how what children go through, determine the rest of their health outcomes. She moved on from her KL2, which is an institutional career development award, to a NIH-funded one. And so she's looking at exclusive breastfeeding in children with sickle cell. And it's going to be this association between breastfeeding and acute care utilization, breastfeeding and asthma. And then AIM2 is a biomarker aim looking at the association between breastfeeding and reduction of inflammation, oxidation, and oxidative stress. And then to demonstrate feasibility that she can get people in a sickle cell community-based breastfeeding support group. So this is Dr. Alonze. So, and here's his awards. So what he's trying to do is, we've been a little bit siloed in terms of Amar's doing his pulmonary stuff, I do my renal stuff. But the question is, why not have a phenotype where you have all of these issues? And so what he was looking at in this paper in pediatric blood cancer was tricuspid regurgitant jet velocity. Liz Kling has told me enough is not pulmonary hypertension, but it is a surrogate marker for pulmonary hypertension. And so whether or not high TRV is associated with, and he did show that it's associated with both kidney and disease and a history of a CNS event. And so it was nice was it was our work, but we combined our work with the St. Jude work. And so there's a potential another project coming out of that to do it a little bit more prospectively. Moving on to the GI program. So again, like Dr. Sadoun, who's a pulmonologist who we've been able to recruit into the sickle cell world. We recruited Dr. DK into the sickle cell world. So she is a GI doctor. So her K award, so her career development award from NIH looks at the microbiome. So again, a hot topic that started probably 3 years ago at NIH is how your microbiome interacts with the rest of your body. So this thought is the gut bacteria, it's there for a reason, but if it gets out of sort, it can become pro-inflammatory. And so there's certain things you can do to improve your gut microbiome. So she created some products, brownies, cookies, pancakes, applesauce pudding, and yogurt. She brought them to clinic and did a taste test. Turns out we've had multiple iterations because NIH felt, despite having issues with weight in sickle cell, that giving patients cookies and Nutella to eat every day was going to create an obesity epidemic in our population. And so now we're having to do yogurt, which is a problem because not everybody likes the blueberry yogurt. And so she has this crossover study. So what happens is she get like stool at baseline, and then they get randomized to either regular diet plus a product that has flaxseed versus regular diet plus a product that does not have flaxseed. They do that for 12 weeks. They cross over, more microbiome studies, do it again for 12 weeks now on the opposite side. But what we've been finding is kids don't like to eat the same product every single day for 24 weeks. And so we are trying to work through that. So the neurocognitive program, so again, another career development award from NIH went to, that's right, it's Dr. Murdaugh. So she's looking at this cognitive remediation of executive and adaptive deficit. So this is something she took from her brain tumor work, which is, can we do this cognitive training and improve outcomes in transition? Also, from a neurocog standpoint, we have the SMILES, which Dr. Cantor alluded to. Again, this is a self-efficacy app. So again, if we can improve patient self-management, then hopefully we can improve outcomes. This one, again, is great. The only issue is they do psychosocial testing. And so we will get phone calls. And unfortunately, if you have, lack of appetite and you aren't sleeping well, that triggers our depression screening. And so on weekends, we're calling, just randomly, we get that popped up because within 24 hours, we need to assess. But the importance of that, though, is we have picked up an actual suicidal ideation in a child. And so we have that. From a neuroheme consortium, we're trying to come up with more things for this group, but 2 studies. So one showing that hydroxyurea can prevent brain injury in children with sickle cell. So Baby Hug is our landmark study of hydroxyurea, but unfortunately there was a death on a child who was getting a scan. And so they shut down the MRI. So we never proved whether or not hydroxyurea could prevent brain injury in sickle cell. And then with Dr. Cantor, we looked at, in this neuroheme group, reducing are the risk factors for silent cerebral infarcts in adults. So sleep medicine, this has been a really interesting addition to our portfolio. So it makes sense that if you have pain, you're not sleeping, but the sleep medicine experts will tell you if you don't sleep well, your pain becomes exaggerated. And so while, and it's completely appropriate for Dr. Sadoun, looking at sleep from a nocturnal hypoxemia standpoint, we need experts out there looking at sleep habits and how that works. So our preliminary data showed, when we look on the y-axis, either sleep disturbance or sleep related impairment, and on the x-axis, whether or not you've been to the ER, both showing that those who are not sleeping well, so this was not the time that they come to the ER, this is just in the last 12 months, but we do show that those who have sleep disturbances within the last week also have more pain admissions in the last 12 months. And then again, looking at sleep in neurocog. So we've submitted resubmitted an R01 with Dr. Thomas and Dr. Fields from WashU to look at, again, more of a sleep aspect. Sickle cell and thrombosis. So Dr. Wilson is studying thrombosis. She has a different path that she's going for the K23, but we do have now an open study looking at thrombosis and sickle cell that's funded out of Hopkins St. Pete. And then we have some pain research going on. The big issue, the take-home points here are these top 2, which again, our patients still feel like, there's perceived racial bias against them, and that worsens their quality of life. And this pain-related injustice. And what that simply means is, if you feel like it's unfair that you have sickle cell, that's the injustice about it, then your pain is going to be worse. And so those who sort of feel like it's not fair that I have it, have more pain issues. And then we just are trying to start up We Decide. So this is funded by PCORI, where we are randomized to the standard of care arm, but it's going to be looking at health-related quality of life, whether you went through on disease-modifying therapy or a transformative or curative. So in terms of building the next generation of leaders, we've done a really good job for our fellows, getting them into, positive careers. We have K awards. So if anybody out there is has a postdoc or pre-doc, we're back in our cycle of, we have no hematology people on these grants. And so we'd love to have a hematology pre-doc or postdoc. So with that, we'll stop and move on. Thank you.
Right, I promise we're almost done. So I do want to tell you a little bit about what we're doing with our philanthropic advancement donation from Dr. and Mrs. Love. This was really a phenomenal donation for us, and we're really excited about putting it to good use. So we have a couple of initiatives under this whole umbrella, and I'm calling it the Love Program Initiative. So of course, the biggest is access. We need to improve access to care and ensuring that individuals throughout the state are getting the care that they need. And so we have multiple areas in which we're doing this. One of them is going to be adapting community health workers, especially for pediatric care, to ensure adherence to hydroxyurea and just improve community involvement in the Montgomery area. We also have a lot going on in mental health, quality improvement, and a global initiative in Nigeria. Oops. So as I mentioned, one of the biggest initiatives under our LOVE program is comprehensive mental health. And so we want to ensure access to pediatric and adult psychology. And we haven't had a sufficient ability to do this for a number of reasons, as well as psychiatry. So this will actually fund an adult and pediatric psychologist to take care of individuals with sickle cell disease. Over time, we will be decreasing the funding from the program and increasing billing funding, as well as from other areas, so that we can make sure that every individual who needs psychologic care can get that care. We're also going to be adapting either a telehealth psychiatry model or working with our transition program called Step Up here to actually increase the access to a psychiatrist. We've really had a limited ability, especially with individuals with Medicaid, getting the psychiatric care that people need. So this program will actually pay for some of those visits to enhance access to that. As mentioned, we also want to increase the outreach program. So in the adult side, we already have a mobile infirmary clinic, and we have a nurse practitioner running that clinic. And then we're hoping to add a clinic in Montgomery or Alexander City to increase access to care to those individuals. For pediatrics, our intervention is going to be the community health worker with a focus on Montgomery as well. And we have specific outcome measures as well in that area. We also can't demonstrate that we're improving quality unless we track quality. So data is incredibly important. So we want to enhance our granddad enrollment, both on the pediatric and the adult side. Ideally, every single individual in our program will be enrolled in granddad over the next 5 years. This really allows us to track important quality initiatives, as well as comparative analysis with other sickle cell centers, and importantly, long-term help us identify personalized medicine in sickle cell disease. So we're also going to have a QI lead under the LOVE program. Dr. Klein, who's our primary care doctor on the adult side, is going to take this lead and really be able to move some of this information forward, as she has been doing all kinds of classwork and IHI and other quality curriculum to improve this. So beware, Dr. Klein will soon be on the warpath, making sure that our patients are getting the eye exams that they need. And then finally, we have some funding, especially in the latter years from this program, going to Nigeria. We have 3 separate projects that we're working on. One is bringing granddad to Nigeria and including them in a biorepository to improve assessment of renal complications and to be able to compare that to what's happening in the United States. We also have a planned collaborative project with our UAB Global Health Program, specifically looking at sickle cell trait that we're really excited about in Nigeria. And then finally working with Dr. Oboro, who's in the PEDS ID group here at UAB at Children's, and also with the University of West Indies on improved newborn screening follow-up, both in Nigeria and in the West Indies. Last but not least, in our last couple of minutes, I want to highlight the incredible important work that Sonia and Sharon are doing in regional and community engagement, looking both at our echoes and all of the different information and didactics that we offer, as well as the newsletter that I'm forever behind on, but working on improving my adherence to the newsletter to make sure that we're getting that communications out to our families every quarter. An impressive increase in social media engagement, because the younger kids are much better at this than we are. They've done a phenomenal job of having students come in and help us with this program. And patient engagement as well, with the Fallen Warriors visual, open houses, holiday parties, and then, of course, trick or treat and Halloween, which is one of my favorite holidays. Ongoing community partnerships really include managing stress, herbal remedies, and really working to improve overall sort of just connection within the community. These are some of the other community events that we'll be highlighting, and hopefully you'll see us even more in the days and months to come. And finally, working closely with all of our community-based organizations across Alabama to really ensure that we're supporting all of their ventures, their walks, and all of their other ventures that are ongoing that we hope to continue to be a huge contributor to and a partner in. And with that, I want to thank our entire team. Maybe, yeah, there we go. I do need a pediatric picture because this is our adult team. And I guess we need some new pictures as we've continued to bring in new members at our clinic and within our research program. And I just want to thank everyone for your attention. I think we're out of time, but happy to take any questions that anyone has. Thank you. And we have actually like 2 minutes, so if anybody has any questions, here or online. Thank you for I'm glad you like the program, and we're very glad to have you here. So thank you for coming. We will be here again. We are here at this time every month with new symposiums and both relating to our internal programs, but also really highlighting some of the amazing external work that's ongoing. Thank you.